Welcome. You are here at Table Talk, a reimagined series created by and for underrepresented communities. My name is Andy Engel. I am Senior Programmer for Reimagine. And for anyone who needs a visual description, I'm a white cisgender male. I got my glasses, grayish hair. I got a bright orange wall behind me. Here is the central question of Table Talk. What does it mean to live and die well, specifically among groups that have been historically marginalized, who experience obstacles to healthcare and death care? Our vision for Table Talk is that it becomes a regular booster shot of knowledge, empathy, cultural humility, and community. While these conversations are by and for underrepresented communities, everyone is invited to these spaces to witness, listen, and learn. And you can view recordings of all of our Table Talks to date at this link that I will paste in the chat if you're curious. There we go. It's letsreimagine.org/tabletalk. Tonight's event will be a roughly 40-minute discussion with our wonderful speakers. And we'll be talking about hospice and Indigenous and LGBTQ+ communities. We'll follow that with a Q&A. And for those who wish, you can click on the CC icon at the bottom of your Zoom bar at the bottom. You'll get a live transcription of what's being said. And you can feel free to send me a note in the chat if you have any issues. So the majority of us are Zooming in from the United States. And we have one of our speakers in Canada. It is also known as Turtle Island by Native Americans and their allies. I am in Lenapehoking, also known as New York City. Let us know where you're located. Please use the chat. And if you want to know about the Indigenous land where you're located, I will paste another link in the chat. There we go. It's native-land.ca. Okay. Now I'm going to briefly introduce our speakers. Lisa Cook has been a nurse since 1990, first as a licensed practical nurse, after which she completed her degree as a registered nurse. And for the past 14 years, she has been employed as a hospice nurse in many, many roles, and she currently serves in admissions at Adobe Hospice in Colorado Springs. According to Lisa, quote, hospice by definition is end-of-life care, but I view it as a transition from physical living to spiritual living. It's beautiful, Lisa. Prior to hospice, she worked in transplant ICU, drug and alcohol rehabilitation, geriatrics, and subacute nursing. Lisa is a member of the Choctaw Nation. Our other speaker is Jeff Lujan. He descends from Atsahem and Manso people. He is a licensed clinical social worker and educator. He's worked with youth and adults in hospice, trauma-informed care, substance abuse counseling, and more. He has extensive experience in multicultural settings, including Hispanic, sexual minority, Asian, Pacific Islander, and Native American communities. He was formerly a high school teacher who was part of the revival of teaching and learning in Hawaiian. He is also a sacred tattoo artist. And this is not Jeff's first Table Talk. Last year, he participated in a discussion about Indigenous perspectives on grief. Lisa and Jeff both live in Colorado Springs, although Jeff is zooming in tonight from Colorado. They are both Native and Two-Spirit. As professionals working in hospice, both are passionate about ensuring that people of all cultural and spiritual backgrounds receive dignified and respectful care. Thank you both for leading this conversation. And before the two of you begin, Jeff, I'd like to invite you to provide some ceremony in this virtual Zoom space.
Okay. Waso sequence lamhanki na atsiheme But I was told by a mentor of mine who's passed on, Frank Seti, that whenever you speak of important things, especially these kinds of things that we're going to be talking about tonight, that always start with the medicines. And what he was referring to was those medicines of sage, cedar, sweetgrass, tobacco. He says, because when we're speaking of things that are important, we need to make sure that those, that the thoughts, this smudge, I've got here, he says it helps us to clear our minds, to focus our thoughts. Because it says it's important that what we speak of comes from here and not from here. He says, because that's where all the problems start. That's when we're talking from here instead of from here. And so, offer up this smudge out of respect for all of us that are participating, for all those ones that we remember and that will come to mind as we talk about hospice and those that have passed on. Of course, Lisa and I have worked together in hospice, and we have lots of, personal experiences that we'll share. But those personal experiences come from being with the lives of people in that very sacred time when they're moving on to that next world. And so out of respect for that, I offer up this smudge to those spirits that we'll be talking about, as well as for all of you, as this topic may bring to mind your own friends, relatives, loved ones that have passed on. And so I just want to offer that appreciation and respect for their lives as well. So that was it. That's I just wanted to start off with that, because last time when we did this table talk, when we started to speak, I said, wait a minute, I gotta light this smudge first before we talk about these things, because that's just how I was taught. And not that there's any wrong ways to start off, but out of respect to those that have taught me, and particularly that Frank Seti, who's taken his own spirit walk. Out of respect for him, I always do that when I do these kinds of things. So I see from Tekpat, she said Tlaskamati, Ashtlen Tekpat, Ashtlen. So I think, Andy, we were going to start off with Lisa. Yeah, so I want to introduce my beautiful sister over here, my partner in crime. We used to be a team, and in 3 different hospices, we've worked together in 3 different hospices. We're kind of like stalking each other over the years, and we always end up in the same place sooner or later. But I'll start off with her.
Hi, gang. So I got into hospice purely by accident because my dad was on hospice service, and he kept saying, I love my hospice nurse, my hospice nurse, my hospice nurse. And I didn't understand that perspective of medicine, because I work transplant ICU and it's all about getting people better. And when I saw how she interacted with him and brought him comfort and brought him peace emotionally, medically, she relieved his pain, but emotionally, she reassured him. I decided right then, I want to do that. I want to bring peace and love and comfort, which is what I got into nursing for. And that is where the spirits want me to be. I've tried to leave a couple of times because emotionally it's tough. but I can't. I just keep being brought back. And so here is where I will be, because it's fulfilling, it's rewarding, and it's tough, and that's okay. It's supposed to be tough. Talking about end of life, talking about death is not easy. It's something that we as a culture are not taught to do. We're not taught that it's okay for natural end of life to occur. In medicine, our end of life chapter is 3 pages long. We don't talk about death. And from a hospice perspective, it's okay to let natural end of life happen and have the support from a medical team that will let that occur comfortably and pain-free, anxiety-free, and is emotionally comfortable for our families and our loved ones, as it can be. And nothing ever prepares any of us for end of life, but the support of a hospice team can make that journey for us better and make us a little more prepared for what happens when our loved ones leave.
Lisa, can you tell us what hospice is? There may be some folks on the call who really have no idea what it is.
Sure. So hospice is, by definition, and this is Lisa definition, not Webster definition, it's end of life care. Medicare says the patient has to have a life expectancy of 6 months or less, or a life-ending terminal illness. A lot of us would say, oh, okay, cancer, but heart conditions, lung conditions, dementia, Alzheimer's type dementia, Parkinson's disease, cystic fibrosis. These are all life-limiting, life-ending terminal diseases. You can have lung disease for years and years and years, but there will come a point where it is no longer curable. The same with heart disease, the same with Alzheimer's disease, or any type of dementia, vascular dementia, senile dementia. I mean, there's a whole host of dementias. Liver failure, Parkinson's disease. Those diseases can have year-long trajectories, but at some point, the life expectancy is 6 months or less. And that's typically when hospice is recommended. Now, some people surpass that 6 months and hospice can continue because the government, in its infinite wisdom, realizes they are not the Great Spirit or the Good Lord or the eternal hereafter, and they don't know exactly when somebody's time on this earth is no longer time. So sometimes that 6 months gets pushed out to 9 months or 12 months, maybe even 15 months. As long as the patient continues to require the services, hospice can continue. But if you look on the hospice definition website or Google hospice, it's going to say you have to have a life expectancy of 6 months or less. That's what hospice is by definition.
Yeah, so my name is Jeff Lujan. I'm currently in Manitoba, which is Treaty 1 territory up here. It's the home of the Anishinaabe and Cree, Oji-Cree, Dene, and Dakota people also. It's sort of where they say the foundation of the Métis Nation was here in this area, this territory. But I also live most of the time down in Colorado, Colorado Springs, where Lisa is. My family's from New Mexico, down by, actually somebody else has family from Las Cruces, and that's where my part of my family's from, down there. Piro people. She'll know that Dominique would know that the Piro people are part of the Tortugas community there in Las Cruces. And then I have my other side of my dad's family is from Tlaxcala down in Mexico. So that's just by way of introduction of me. For me, hospice is, in addition to everything that Lisa said, it's a service. There was a time where they had hospice houses, and sometimes people think of hospice as that it's a place where someone goes at end of life. But nowadays, especially in the United States, it's a service that comes to you or to the person that's in need, wherever they're at. Could be at their home, could be in a nursing home or assisted living facility. When I was working up in Montana, in Billings, sometimes the hospice services were being provided to people in a hospital up there, just because that's where the person was. And so we would go in and provide services. And so rather than thinking of it as a place, it's a service that's provided to people and their families. So it's not just the patient, but there's that support that's provided to everyone that's involved, to the caregivers. And so in the United States, part of what hospice team is, there's a registered nurse, there's going to be a chaplain, social worker, a CNA, and of course you have to have a medical director, somebody that's signing all the documents in the script. But that team is there to provide that wraparound support for people. And for years, for the first maybe about 5 years or so, when I was doing hospice, people would say, so what do you do? I don't understand why we got to have a social worker because we don't have any kids. Like if that's the only thing we do is go take away kids. No, it has nothing to do with that, you guys. But, so I go through all the different types of services and different things I can help with. And then I happened to be watching PBS one time, and they were doing this documentary on Sir Edmund Hillary, who was the first person to summit, Mount Everest. And they were interviewing this man who was, they called the world's oldest Sherpa. And he had been just a young teen when Edmund Hillary went up. And since that time had been up that trail hundreds of times. And now he was the one that younger Sherpas would go to. And he was like their mentor. And he could look at that mountain and say, it looks like this, those clouds are coming this way. These are the kinds of things you're going to need. And I would recommend you take this path. And as I was watching that, then the light bulb went on. I'm like, that's what I do. I'm a Sherpa. I help guide those patients and families through this journey. And I kind of look at the weather that's coming in based upon, you guys see the cat over there. I'm at my friend's house. The cat wants to be on Zoom. But that Sherpa looks at the conditions and makes those recommendations. Say, you're probably going to want this. You're probably going to need that. And that's kind of what my role is. And I think for all of us in hospice is we guide that family, that person in that journey. Because as Lisa said, especially in our modern culture, we do a real terrible job of preparing ourselves for the thing that all of us will have to go through. Nobody gets out of this game alive. And there's a saying in that comes from Mexico. It's a Nahuatl saying. It says, Nochi patla, nochi tlami. Everything changes. Everything comes to an end. And that becomes just a foundational reality of our life. But in our Western culture, we often behave as if everything will be the same. and nothing will ever come to an end. So even just the challenges that we face as we physically age, those changes are tragic enough in our society. Boy, we just collagen injections and facelift kind of stuff, because we try to deny the fact that change happens. But that final change is the end, right? That change from this world to the next. And so as as a person of Indigenous heritage, I think that's part of how that informs my practice, bringing some of these teachings and lessons in to share with when it's appropriate. I mean, I'm not like a, what do you call it, Bible thumper. I'm like, oh, you guys all gotta go jump in a lodge. Although I think some of our family members, I need to cook them up, because then they'll just smarten up. That could help some of them out, but I'm just kidding. But that's in the background of my understanding, and helping sometimes reframe those conversations that can be profoundly terrifying, right? Because for many people, they've never talked about it until it's right there, right? And unlike other things, again, within our society, that's one of those things that nobody wants to talk about, right? Even if it's happening. When you're about to be married, I think I said this the last time, when you're about to be married, everyone's got advice, right? If you're gonna have a kid, everybody and their grandma's got advice, right? Got, things to tell you. But if they say, hey, how's everything going? Okay, but my uncle's on hospice, I'm taking care of him. And then it's like, oh, wow, okay, yeah. Then crickets, right? And a lot of times that's how people that are in the midst of that feel. It's like it becomes really emotionally isolating, socially isolating, physically isolating to be in that space. And so that team comes in, the hospice team comes in to help provide support and walk with you, walk with the people as they're on this journey. I tell you what, I mean, I'm talking lots, but so much of what I know about hospice work I've learned from my co-host here, Lisa. She is an amazing hospice nurse.
Well, thank you, Jeff.
Yeah.
But I was just gonna say, don't get Botox, don't get collagen, because from a nursing perspective, I tell my patients and my families, look for the 11s, these lines right here, because that's how you tell if people are in pain. This is what we call a nonverbal indicator of pain, the 11s right in the brow. But if you get Botox, if you get collagen, you can't make that face. So unfortunately, you'd be on your deathbed, nobody knows you're in pain because they can't see the 11s. So they're not going to give you the good medicine. So, I mean, I'm making light of that, but the fact of the matter is what we need to do as lovers of our families and lovers of humanity really is learn what those nonverbal indicators are. Maybe it's just a furrow of the brow. Maybe it's talking through clenched teeth. Maybe it's holding our breath, because those not only are indicators of pain, they're indicators of emotional distress. They're indicators of anxiety. They are indicators of agitation. And you can be in a room of 50 people and somebody's jumping up and down, going to the bathroom, getting a drink, going outside, going over here, going over there. That's typically because they're uncomfortable with whatever's being discussed or whatever's going on. That's an anxiety response. And we see that in our patients, but we can see it in our peers. We can see it in our coworkers. We can see it in our loved ones across the room if we bring up something that's uncomfortable. So forego the Botox, forego the collagen, because you really want people to be able to see your true facial expressions. And if that's a little laugh line or a little wrinkle or a little furrow brow, that's okay. My grandmother used to say, wrinkles come from wisdom. And I like that, because the older I get, the more wise I get, as indicated by the wrinkles. So if you think I got a wrinkly face, I think that means I'm really, really smart, really wise. So I'm going to just believe that. You know, from a real world perspective, not the medical side of it, but from being the side of it that I was my father's child, watching him go from life to end of life, from physical living to spiritual living. I was a nurse for 15 years before I knew about those nonverbal indicators, before I knew how to tell if somebody was uncomfortable. And it's the greatest gift you can give anyone, to be able to provide comfort. Maybe that's holding a hand. Maybe that's providing the medication. Maybe that's a cool rag for, you know, a forehead or a chin. Maybe, just maybe, it's sitting on the couch with a spouse of someone who is sick and who is soon to be not in the physical plane anymore, and just quietly holding a hand. Because we as humans need to be able to recognize when the other humans around us are in distress. And we need to be able to provide some sort of comfort. Maybe it's a smile, maybe it's a glance. In this day and age of COVID, with a mask on everybody's face, you can't see if somebody's in distress. But if you look for these 11s, you can see it. If you look behind the glasses, you can see if people are smiling. You can see if people are sad. You can see if people are emotionally distraught. If we just look right here, the eyes are the window to the soul. If you just look in somebody's eyes, you can see what they need. And mostly what they need is just reassurance, just a little comfort. And just to know that somebody sees them and sees what they're going through.
So to that end, Lisa, I just wanted to, because I know part of our focus is, or with this tabletop series, is around those, you know, communities that usually don't have a voice. So I guess, how has your experience as a Two-Spirit woman, as an Indigenous woman, how has that informed your hospice care? Or,
you know, for me as a Two-Spirit woman, I go into everybody's house looking for Two-Spirit people so that I can communicate with them and let them know that they're understood and they're accepted. I'll be honest, in Colorado Springs, Two-Spirit folks are hard to find, but that's okay. The not Two-Spirit folks are okay too. And again, I'm just being silly, guys. But you know, if we can help our community understand, because hospice doesn't care. Everybody I've met in hospice is open and welcoming, from social workers to chaplains to nurses aides. You know, if you have a spouse that's of the same sex, if you have a heterosexual partnership, um, it's great. Everybody is welcoming. There's not that judgment that you see in typical like hospital settings. I encourage all of my Two-Spirit friends to let people know who they are so that they can receive the services they need. You know, if I keep my wife in the shadows, if I keep my partner quiet, oh, that's my friend, that's my roommate, that's my best friend. The hospital, the medical professionals don't have to treat her with the respect that she deserves. So from a hospice perspective, we say, if you say they're family, they're family. It doesn't matter if they're friends or if they're the neighbor across the street or they've been your significant other for 20 plus years. You determine who is family. But medically, in the hospital setting, there's all these regulations. You know, you have to make or prove that that's your significant other, or you have to have a medical durable power of attorney in place so that patient or that person can be in your room if you're ill. So I encourage everybody, legal married or not, significant other or not, neighbor across the street, whoever it is that you want to speak for you, to make those decisions. If you cannot, put it on a piece of paper. It's called medical durable power of attorney. If I am unable to speak for myself, this is the person that's going to make these determinations. And make sure that that person knows what those determinations are. Yes, hook me up to all the machines. No, don't hook me up to any of the machines. Yes, do CPR. No, don't do CPR. Yes, I want surgery. No, I don't want surgery. Not just centered around Two-Spirit folks, but just around healthcare choices, period. You'd be crossing the street, get hit by a bus. Somebody's got to make decisions for you. You know, please, if you get nothing out of this discussion, and I hope that you do, and I think that you will, please, please, please start to think about what you would do. Who would make the decisions if you could not? If unfortunately you get hit by a bus crossing the street, who would make the decisions when you can't speak for yourself?
Lisa, I'll just jump in because you shared with me before our call what your day was like today, and that one individual that you talked about. Maybe you can share with the rest of the group about this young man.
Yeah, the last patient I saw this afternoon, 36-year-old gentleman. He might survive 3 days. The really sad situation is that he was diagnosed with cancer in 2016. He was 29 years old. He's had a lot of time. 7 years is a long time with cancer. He's had a lot of time to think about, do I want CPR? Do I want to be put on ventilator? Do I want to have a tube placed for nutritional feedings? Do I want to be in the hospital repeatedly? And he didn't. I talked to his wife today. I said, does he want to have full resuscitation? Does he want to be put on life support? Does he want an artificial tube? And this 35-year-old woman looks at me and says, I don't know. I don't know. Well, as gentle as I could, you've got about 3 days to make that decision. because at some point his heart is going to stop. And I need to know, do I do aggressive CPR? Do you want your 7-year-old and your 6-year-old to see me do aggressive CPR on their daddy? And that's tough, gang. That's a tough conversation to have, but it's a tough conversation to receive. That poor lady panicked when I said, what do I do? Because she didn't know. And I get it. He's 29 years old when he got diagnosed. He's going to beat it. He's going to watch his kids grow up. I understand. I do. I'm not 29 years old. I'm over 50. But I'm going to see my grandkids grow up, and I'm going to see all of these things I want to see. I'm going to get to Europe someday. But what happens if tomorrow I get hit by a bus? So these are very important conversations that we need to have with our parents, with our children, with our significant others, maybe with our elderly neighbor. You know, I said I'm over 50. My kids are 25 and 23. They know what I want, but I know what they want. That's the important thing. It's okay to talk about end of life. Talking about it doesn't mean it's going to happen tomorrow. It just means we're prepared when it does happen. You know, I think if we can give anybody any grace, it's them knowing what we want if we're faced with a terminal life-ending situation. And I, for one, choose to die with dignity. Dignity being not being on a ventilator. Dignity not having every rib in my body fractured. Just let nature take its course. That's not everybody's choice, and that's okay. But it's a discussion that needs to be had. However you want your wishes carried out. It's a discussion that, quite frankly, I had to have with my 76-year-old mother. Mom, 76. What am I doing? Am I being aggressive? And I'm not being aggressive. You know, my mom and I have that kind of relationship where we talk like that. She knew exactly what she wanted, but she had never said it to me. Now I know. Now I know how to proceed. She wouldn't have said it to me if I hadn't brought it up. I think it's okay to have these very real discussions. Again, it doesn't mean we're going anywhere anytime soon. Just means that somebody knows what we want in case.
I know that, and part of the reason I thank you, Lisa, for sharing all of that, because part of the reason I was asking is because I know that, like yourself, my experience is when I'm working with people, actually any of the different venues that I work with, I'm much more sensitive to those people that might be two-spirited or LGBTQ or however they self-identify, that don't feel comfortable yet to bring that out to their providers. Unfortunately, before the 2015, where marriage rights were recognized by the Supreme Court and across the nation, I remember one of my earlier hospice patients, because they didn't state, because there was still conflict with the family. As a younger person, but because they didn't make that designation of their lover as someone that could be there when the person became unable to make those decisions for themselves. That proxy process put the person's mother in charge, and the mother would not allow that person's life partner to be in the room as this person went through the end of their life. And I remember I was just like coming unglued, but there was no legal recourse because it hadn't been put on paper. And you know so that's, you know, for all of us out there, you know, even if nothing else, set those people that are going to make those decisions for you. You know, who's that MDPOA? Who's that person that is authorized by you to speak on your behalf when you can't? Because if you don't make the decision, what ends up happening is a court will make it. There'll be this process that'll go through. You know, they'll appoint somebody, or you know, maybe if there's no contention within the family, there's a proxy process and a doctoral sign off. But usually it goes in that order of who's closest related to you. And I can tell you there are some relatives, my relatives, that I don't have anything to do with making decisions for me. It's like, I come from a big family. There are some folks that's like, no, you just, yeah, I don't want them in there. Their opinions and their thoughts about things.
Well, the good thing to know, sorry, Jeff, didn't mean to cut you off, but the good thing to know is you can determine who that medical decision maker is without labeling them.
Yeah.
Okay, I'm going to make Jeff my medical durable power of attorney. He's not my lover, but he's the person I want to make those decisions. So you don't have to say, Jennifer's going to make my decisions. And oh yeah, by the way, she's my wife. You never have to come out on that document. Just who is going to make the decisions when I cannot.
The other part about that is, you know, as we're talking about hospice, is as you talk with that person, especially for anybody, to have that conversation with the person about what are the things that are important to you to happen at end of life, especially, you know, as we're talking on this BIPOC people, right? And people of color, people, Indigenous people, we all have sometimes within our families certain traditions and things that need to be done or that should be done or shouldn't be done around end of life. That's a really important thing to share with that person, especially if you're not around that community. I've run into that a couple of times as well during my work with hospice, that there are certain things ceremonially that can or can't be done, depending upon the people. I know that within certain cultures in Southeast Asia, they have really strong traditions around who's allowed to touch the body after the person is passed. That a woman that hasn't gone through that change of life shouldn't touch the body. That a woman that's already gone through that change of life can touch the body. And one of the things that, and I know some Indigenous tribal groups here in the United States also have those feelings. And one of the teachings that was shared with me by some folks that are up in the northern part of the United States was that those women that are still of childbearing age, their gift, their role is to call life to the earth. And that when this person has just passed and that spirit is still close to the body, that she shouldn't be touching him, because just in case she calls that spirit back and that spirit is trying to leave. But that woman that has already gone through that change of life, her body is no longer in that space where it's calling life into this world. And so she can take care, she can touch that body. And so when those cultural beliefs are there, it can become really disconcerting that a very well-intentioned CNA that's, you know, in her early 30s might touch that body, because then the family members are going to go, oh my gosh, now my loved one's spirit can't travel in a good way, might be called back. So for those cultural protocols to take time to share those things somehow, even if just writing it down, like for many people, it's important to have that window open. I remember we had that situation at Pikes Peak Hospice where the lady smashed the window because the window wouldn't open. And she was concerned that her spirit was going to get stuck inside. So just having that written down somewhere, and that person, that friend that you trust, say, hey, this is where you find this. God forbid I get hit by a bus tomorrow. These are the things that need to happen. You know, if there are those types of things that should happen. And those are unfortunately things that sometimes, just out of true ignorance, meaning, you know, not having an awareness of it, those are sometimes the things that can be overlooked in emergency medical situations, or you know, when people are being cared for, when you no longer can speak for yourself. So those things that are really important, you want to find ways to record that, to communicate it, and to let, you know, somebody know, especially if you're away from your community of origin. You know, people that are, let's say, for example, Dene or Navajo, and they're there on the Navajo reservation, and it follows traditional ways, and they're surrounded by that. They show up at the hospital there in Chenli, they'll know those things, those protocols, those kinds of cultural ways. But if that same person is, I don't know, in Valdosta, Georgia, might not be a lot of Navajos around to guide, you know, on what's supposed to happen. You know, if that's your way. So yeah, those are just, I mean, on top of the other things that we've been talking about, those are some of the things that I would, you know, I guess, encourage people to think about and find some way to just have it recorded. So, you know, put it together with those powers of attorney and those living wills, those final wishes, so that people, you know where to find it and what needs to happen.
Jeff and Lisa, there are some burning questions in the chat already, which I'm starting to collect. I would also love to open up the floor, and you guys can unmute yourselves if you want when we're ready to have these conversations. You know, and if you want to turn your cameras on, you can do that. But first, I want to say that, you know, Reimagine as an organization, you know, our mission is to encourage folks to reflect on mortality and loss and other kinds of adversity, and how to transform those difficult experiences into growth and into action. My question is, if there's someone in your life, you know, a friend, a lover, a family member who is resistant to having any kind of end-of-life conversation and the prospect of hospice care, what small, sweet step can you take to open up that conversation?
For me, what I encourage families to do is say, do you want me to take you back to the hospital? Do you want to be hooked up to those IVs? Do you want that fluid? No? Well, let's talk about palliative care. Palliative is symptom management. Usually palliative care and hospice care go together hand in hand. Palliative care is for the person that's not necessarily terminal, but they have a pain or shortness of breath or some symptom that needs to be managed. Let's talk about palliative care. So if you have that palliative care conversation, how do you want me to keep you comfortable? Then it's a little easier to work into that hospice conversation. You don't want to go to the hospital. You don't want antibiotics. You don't want IV fluids. You want to be here. You want to be comfortable. You want to be pain-free. Those are all what hospice does. Not saying you're leaving today, not saying you're dying next week, but let's look at getting you some additional services in the home, in my home, in your home, in your sister's home, wherever the patient resides. Doesn't have to be their physical home. Let's just see if this would be beneficial. If we can ever get them to agree to let one of us come, social worker, chaplain, registered nurse, we can talk to them about the benefits that they can receive using hospice services.
Yeah, that I know that there's challenges within certain sometimes cultures too about even talking about it, right? And there's I know with again with many traditional Navajos that you don't talk about that. That to talk about is almost to invite it. And because of that, even pre-planning for needs, if you want to have a business that's not going to do well, that's try to sell prepaid funeral plans on the Navajo reservation, because you just don't do it. It's at the time of need that you go out and get it. But to pre-plan, there's a belief that to talk about it and to even like pick out your plot and what's the casket and all that kind of stuff ahead of time, that's almost like calling it in. So they'll never have those conversations in that kind of way. But outside of that, within, if like you were talking, Andy, you were talking about a friend or a family member that may need to be having that conversation. Sometimes there's those teachable moments. If you bring in and say, hey, oh my gosh, did you hear about so-and-so? Or make up a story. You can say, I was just reading the other day about this poor man that all of a sudden he got sick and he hadn't made his, assigned, and it's true, I've seen it happen, in my own work, but this poor man, he didn't have anybody set as a POA. His advanced directives weren't in place, and because he was brain dead and couldn't make decisions for himself, then it had to go to court, and a court had to appoint because the family members were fighting over who. I think dad would want this, I think so and so, no, that he would want this, and so they had to go to court. And in the meantime, this guy's just stuck on a machine until the person was designated who was going to make that call. And so, even bringing up those kinds of cases is like, God, and then it kind of naturally can lead into a conversation like, oh, good Lord, I would not want that to happen to me. Oh yeah, well, what do you want to do? And sometimes it bringing those examples of, what can happen if we don't plan, and I'd hate that to happen to you. What do you want, Andy? Have you ever thought about that? If you haven't, just for example, I would hate to have that happen to me. Have you ever thought about that, Andy? I mean, have you figured something out? I'm going to go down and write this down. And that might be through a natural conversation, linking it in. Maybe that might be an easier way. But for some people, it's just going to be, there's going to be resistance to talking about death and dying. And then, like Lisa was saying, just focusing on, okay, well, these symptoms, how do you want us to manage these symptoms? If you start getting really short of breath, do you want me to call 911? or do you want me to, and just kind of taking it baby steps. You can engage it.
Thank you both.
I saw some questions in the thing about if there's and thank you, Andy, for that resource about SAGE. That's a really good resource. I don't know of any one book that's going to, and I would always caution against that. Oh, here's this book, and this is what these people believe, and these people, because even within a community, a particular community, I think I said that the last table talk, as I was sharing some thoughts about grieving from Native American perspective. I said, I can share some things that I've been told. I said, but within the Native American community, there's over 500 tribes here, just in the north part of Turtle Island, right? Over 500. And then within any given community, there's all these different teachings and different family traditions. And so even to say, within the Anishinaabe community, where there's lots of variety and different teachings amongst the Anishinaabe people. Or you could say within that community, it's close to here, Sagin. Just within Sagin First Nations, there's all these different teachings. So it's going to be really hard to find anything. And I would be cautious of anything that's just puts out general terms of, this is what these people believe, and this is how you deal with that. But just one general thing, I think, for anybody that's working in these types of fields or working with somebody, is respectful curiosity and being out front and open. Like, I don't, where you're from, what is important to you? That's one of the questions I often start off when I'm first introducing myself to a patient and doing that initial assessment. I'll just ask them, in the time that's left, what's important for you? What's important for you at end of life that happens? And that's when they'll tell me things like, I'm Orthodox Jewish and we have to do these things. Or this one lady that was from Cambodia, and they had some very particular things about what could and couldn't be done, or should and shouldn't be done with the body. When I was up in Billings, Montana, there's 5 different tribal groups that are serviced right there in Billings, and all of them have different traditions around how they deal. And then even within, like on the Crow Reserve, there are people that follow traditional ways. And then this one lady, I was saying, so you're over there from Crow Reservation. She goes, yeah, but my family's very staunch Catholic, so we don't do that. I'm like, okay, good to know. So it's, what are those things? What's important for you? I think that's the simplest question, but the most powerful. Because that might even be more telling than what's important for your family. What's important for you?
Dominique, thank you for sharing that in the chat. Dominique, you shared something earlier. I don't mean to put you on the spot, but you shared something so beautiful about your grandmother. Maybe you could, if you're willing, if you could elaborate a bit more.
Yeah, so I have a mixed family, so it's Hispanic with some Indigenous, but not what you would consider like the blood quantum. But I have a lot of family in Torturas, and it's considered a pueblo, but it's not federally recognized, unfortunately. But I still, continue the tradition and what I could find from family history. But when my grandmother passed away, something in my mind, it wasn't said or anything brought up, but something I learned is about keeping a window open to let your loved one pass away. And that's what I did. So once we got her into hospice, I opened the window up to let that fresh air in and just help with that. But like, it wasn't planned or anything, like something she said, but maybe spiritually, who knows? Because like it was running through my mind to open that window. But I would say it was a beautiful moment. Unfortunately, when she took her last breath, I wasn't in the room. I left, but a lot of family believe is that that's what she wanted, because I'm the only granddaughter. So I guess that's how I take it with my grieving, that she just didn't want me to be there when she took her last breath. So,
You know, it's interesting, Dominique. Those folks are so in control of when they leave and how long they stay.
Mhm.
When my dad passed, he stopped breathing and did not have a heart rate every hour on the hour for 12 hours.
Mm.
There was no clinical reason why he should be alive, except he would shake his head no, he would take a big deep breath, and his heart would start again.
Oh,
The
wow.
fascinating part is that my brother was on an oil rig 12 hours away. And when Rick pulled in the driveway, I said, Dad, Rick is here. He's here. My dad passed before Rick could get from the driveway in through the front door. He
Mhm.
just needed to know his son made it safe. And I believe that with all of my heart. I was standing beside him when it happened.
Mm.
I had a daughter who sat vigil with her mother for 72 hours. That lady only stepped 5 feet away to go to the bathroom. And I came in and I said, you need to take a break. Let me sit here with Mom. You just walk around the house, get a cup of coffee. It'll be okay. The daughter left the room, was in the kitchen pouring coffee, and her mother passed away. Mama did not want her daughter to see her leave. And so those folks have complete control, and they will either stay or they will leave when they're ready. So, I tell every family member, you set bedside vigil, and the minute you get up to go to the bathroom or get a cup of coffee and they leave, it's okay. They're protecting you
Mhm.
from carrying that vision. And maybe they shouldn't be here. And the nurse keeps saying, I don't understand why they're still alive. I don't understand. They're waiting on their brother to get in, or they're waiting on their son to get off work, or maybe they're waiting until after the granddaughter's softball game. Who knows?
Mhm.
But they know.
Mhm.
So we have to respect that in them. And so I try to encourage everybody, it's okay if they leave when you're not here. That's just them tipping their hat to you. They love you.
Right. Yeah, and it did take me a while. In that moment, I was like trying to process everything, and I didn't understand. And all like I just went for like 30 minutes, and and I was there all day, and that's what the family was telling me. Well, that's what she wanted, and they processed it with me, and after that, I accepted it. It just took a while. Mhm.
Of course.
Are there other folks, particularly folks who identify as Indigenous or LGBTQ plus? If you guys have any questions, feel free to raise your hand, unmute yourself. We'd love to hear from you.
I'll go. My name's Melissa Gonzalez, and I am of Dene and Apache, but unfortunately, through time, I don't know the traditions of end of life, and it's great to hear what I just heard so far, and I'm so intrigued. What would be a good resource for me to understand more this lineage and to have an understanding, because I am an end of life doula also, which is really interesting to be of that lineage and be an end of life doula. So yeah, if there's any resources, I'd love to know. Thank you.
I'm not aware of any like written resources, and that's going to be for a lot of I mean, just in general for a lot of tribes. Outside of the occasional thing that an anthropologist may have collected during some sort of an interview that happened and then gets published in a paper. Those are things that aren't often like, at least that I'm aware of. You know, I don't know, like, oh, here's the Lakota way of death and dying. Although the ceremonies are there. I mean, there's definitely ceremonies. There's definitely specific things that are done for different tribal groups. The best thing I could say, you know, is to make connections with people from that community. However you can. And, you know, I wouldn't start off by, hi, I'm Melissa, I'm a death doula. How do you guys die? You know, not so much that way. I didn't think you would do that. I'm just being silly.
Yeah.
But you know, as you make those connections, and then at some point, you know, as you talk about that, and then just because that's what you do, you're probably likely within people from those communities, they're like, oh, wow, that's, you know, we usually don't talk about those things, but yeah. You know, or they'll say we don't talk about that ahead of time, and that those are when those little things that will come out.
Mm-hmm.
I have, you know, quite a few friends from the Navajo Nation, and so I've been, I don't know if you'd say opportunity. That sounds weird, but because of that, because of the close connections, is when those loved ones pass on. You know, oftentimes there for those observances that happen. And so that's when I started to, because I asked my friend, like, oh my gosh, they were putting together funds to pay for the funeral. It's like, oh, did they not have any kind of prepaid plans, needs? And they're like, and that's when they told me, no, we don't do that. You know, we never do that. You know, it's when it happens. But it's also an interesting thing because of that, how the community comes together. And then it's during sometimes those wakes that might happen. So everyone's coming and paying their respect. People give a little money here, a little money there. And then by the end of those 4 days, everything, all the resources that the family needed was there. And so it's just a community understanding that this is our time. We come and we help this person. Next week, it might be me that needs that help. And they know that the community will come together again in that way.
Jeff, there's a question from Tecaptl.
Hi, I think I'm unmuted. Hi, Halito, or Piali. I want to say detribalized. So my mom is Indian residential school survivor. I'm Two-Spirit. I'm raising Two-Spirit children, and we have our titles. We're Choctaw, Chickasaw, Mexica, Taino, and Amasi. And so, like Melissa, you know, having maybe not that connection, I just keep getting we're supposed to go find elders in our specific communities and learn that way for the maybe ceremonial things that we're supposed to offer back to our communities if we're taking on that role. I joined this to kind of hear what other Indigenous people were doing in terms of this work in a colonial setting or setting, which is interesting to hear because I am younger. I'm not quite there yet in that realm of work or career. I'm sort of entering in that. And so it's good to hear, and then also interesting to hear what we're offering, and that the space or maybe the people we're being of service to, that we're actually able to incorporate more of our cultural stuff if we were in a setting that was not our community or our cultural setting. Does that make sense?
Yeah.
Yeah.
I've definitely, and Lisa and I had a patient that we shared. that I think you know who we're talking about. But it was interesting when I first came on board. I was doing the onboarding and telling her about hospice services, right? She'd already she'd already had the explanation services, but it was my first meeting with her, and I was just she says, "Tell me a little bit more about this so I understand." So I'm telling her, and I told her about the chaplain, and she's like, "Oh, no, I don't want any of those people praying over me. I don't believe in that." I'm like, "Okay, this is like Burger King, girl. You get it your way, right?" It's like, if that's how hospice is. However you want it, that's how you're going to get it. And then as I was talking to her, her father was Lakota, but he had passed when she was about 5 years old. And then she ended up going back to Massachusetts and being raised by her mother's family. This would have been back in the 50s. And the mother's family really didn't approve of her mom's hooking up with this native guy in the first place, and said, "Okay, well, we'll help raise your daughter, but she can't go back there." So she had this awareness and had some vigorous connections, but no deep connections as far as with her own family. And so it was when I had left for the summer to go to ceremony one time, I told her, I said, "Well, I'm going to be gone for 2 weeks. But when I come back, we'll pick up with regular visits. But in the meantime, if you need anything," I gave her some numbers, and she goes, "Where are you going?" And I said, "Well, I'm going to ceremony up in Montana." And she says, "Oh, we'll have to talk about that when we come back." I said, "Okay." So we started talking more and more about it. She asking more and more questions. And eventually she asked me one time, she says, as her condition was changing, she's starting to have some anxiety around her nearing death. She says, "Can you do that smudge thing for me?" And I was like, "Well, yeah, I can." I said, "But I don't want to offend you. You said you didn't want anyone to pray over you." And so, I mean, that's smudging, that's a prayer. She goes, "Oh, that's different though. We can do that." So I was like, "Okay." So I brought my sage in, and we had to take her outside because, it set off all the alarms in the nursing home there. But we went outside, wheeled her out there, and sang songs for her and smudged her off. And then after that, there's this Eddie Three Eagles, we brought him in, and he did some songs. And then as she was getting closer to the end of life, she said, "When I die, will you come and sing for me?" And I said, "Yeah." And this is a patient that Lisa and I had shared together. And so, we put the notice out for the people that were taking the on-calls, if she passes, to call us up and let us know. And she passed. Lisa and I went out there and we opened up and that even though the nurse said, "Well, you can't be burning that sage in there," after we got that nurse out of the room, we closed the room and we smudged her down, and we sang. I had my drum with me, and we sang the songs and sent her spirit off in that way, how she wanted to go. And so that's, in our hospice, I'm kind of like the default guy when somebody comes around that's not, traditional spiritual. To send me that. But a lot of it is, it's guided by the patient, and if they want that, if that's what they're interested in, then we'll do that. Recently, I had another patient. I actually flew back from Canada to be with him. He was going to take that cocktail, the Medical Assistance in Dying Act. He had ALS, and it was getting to the point where he's having difficulty swallowing, and he knew where it was going to go, and he chose to have that medical assistance in dying. And he asked before I left to come up here to do work. He says, I asked him that question. I said, "What do you want? What do you want when it's your time?" And he says, "I want you to come sing for me." I said, "Okay, I'll do that." So there's definitely the potential to integrate this, but always like with every other thing in hospice, it's always patient driven. It's what they want when they want it. But there's many times that those cultural perspectives, I use those to help to reframe people's understanding and their ability to just look at end of life in just a little different way that helps them to appreciate it or make it a little bit gentler. Like, for example, one teaching that I got, sometimes you see people get really restless, when we call it terminal agitation. But that gentleman that I mentioned earlier, Frank Satie, he told me one time, because he was a social worker too, as well as a Sundance chief. He told me, he says, when you see those people at end of life, they get really restless sometimes. And I said, yeah, I said, I've noticed that. He said, have you ever seen a snake when it's going to shed its skin? He says, it's 2 times you're most likely to get bitten by a snake. It's just before and just after a snake sheds its skin. He says, that snake doesn't feel right in his body anymore. It doesn't, that the skin is too tight. And he says, and for us, as our spirit is ready to move on, this body, this shell doesn't feel right anymore. And, people are like wiggling. And he says, it's just like that snake rubbing up against trees and branches and rocks, trying to move out of that skin because it's too big for that old skin. And he says, our spirit at some point gets to a place where it's too big for this body. It's ready to move on. And then you get that agitation. It's trying to wiggle out. And so I share that teaching with people so that they gives them context for what they see their loved one going through. Say, oh, it's just something that I was told. Maybe give you a different way of thinking about how that works.
I always say it's a physical expression of a spiritual desire. And that helps families get it sometimes. And most generally, people will rip off clothes and throw off blankets. And I always say we come in this world without clothes on, and 99% of the people go out of this world without clothes on.
Folks, it's 9:18 now. We're a little bit over. We have to wrap up, but I wrote in the chat, everyone will get a recording of this, and please share it with others. I hope you all agree with me that we had some amazing speakers with so much wisdom, also 2 great storytellers. And I also want to thank all of you who asked questions, both in the chat and verbally. I think we all learned a lot from you as well. And stay tuned. We'll be having more table talks this year. I hope to continue working with both you, Jeff and Lisa, on table talks and other Reimagine programs in the future. So I want to wish everyone a beautiful evening, health, and I hope to see you at other Reimagine programs. Any last words, Lisa and Jeff?
Thank you, guys.
Thank you. Yeah, thank you. It's been an honor, and take care of yourselves, everyone.
Absolutely.
Good care of yourselves.
Good night, everyone.
Good
Good night.